Good evening, everyone. Thank you for joining us on this beautiful April day. We're thankful that you are here with us and excited to share some updates and have some discussions with you all this evening. If you'll go to the next slide, Melissa, this is hosted by OPQIC and the Oklahoma Hospital Association, where we now reside. We request that each of you rename yourself on Zoom or type your name into the chat box so we can recognize who is attending the meeting this evening. Just a brief overview of our agenda this evening. We'll have a few OHA updates first, and then OSDH Maternal Health Task Force updates, OPQIC, and then OHCA. And it got cut off at the bottom, but we're going to have a discussion on testing for rupture membrane in the emergency department of non-OB hospitals. So first up on our agenda, we have Rich Rasmussen, who is the president and CEO of the Oklahoma Hospital Association. And Rich, I will turn it over to you. Thank you for being here with us this evening.
All right. Thank you, Barbara. I'm going to spend a few moments talking to you about a real risk factor impacting hospitals, and it is the potential for Medicaid cuts. And we've spent a lot of time as a country, most recently, talking about what? Tariffs, right? It's the issue du jour. But in the background is something that is incredibly disruptive for the work that each and every one of you do. And it's what would happen if we lost the ability to provide coverage to over 300,000 Oklahomans. What would that mean? And so I'm going to walk you through a couple slides. But before I do that, I'm going to show us a video that has been produced by the American Hospital Association, the coalition that they have in place, that they're messaging principally in Washington, D.C., and trying to provide some additional education to our members of Congress in terms of what these Medicaid cuts will mean. I'm going to try and run this for you, and hopefully it's going to allow me to do it. All right. Give me a second here. Can you all see the black box on the screen here?
Yes.
All right. Let's see if we got the audio set up correct on this thing. So give me 1 second here. Okay. Well, let's try it. If the audio doesn't work, then we'll paraphrase it, okay?
Medicaid covers health care for 72 million Americans, helping seniors, veterans, and children. And President Trump wants to protect them.
Medicare, Medicaid, none of that stuff is going to be touched.
Trump is standing up for Medicaid because Americans rely on it.
We're going to love and cherish Social Security, Medicare, Medicaid. We're not going to do anything with that.
So why are some in Congress still trying to cut Medicaid? Tell Congress, don't cut Medicaid.
Are we all able to hear the audio for that?
Yes.
One of the biggest barriers that stops people from getting their pilot's license or pilot certificate is, of course,
There we go. So I'm going to turn this back over so we can look at some slides. So I'm going to go ahead and let go of my sharing here if I can. Do you guys have the screen back?
We do not.
All right.
Yeah, we're still seeing it.
All right. Let's stop it here. Oops. There you go.
Yeah, we did. We're good.
Okay. Perfect. So I show you that video just to kind of tease out for you kind of what we're going to be dealing with here over the next 3 to 4 months. And so Medicaid is the single largest payer for whom? For babies. In most states, more than 50% of all the babies are covered by Medicaid. And in states like Oklahoma, which are expansion states, not only do we cover moms and babies, but we also cover our working poor neighbors and friends. And so it is a critical part of what we do in providing care for our patients. And so there is within Medicaid we fund hospitals, we fund in Medicaid expansion, we fund hospitals, we fund physicians, we fund pharmaceuticals, durable medical equipment, and so forth. Part of the way in which we do that as it relates to hospitals is that hospitals are paid through managed Medicaid in our state. And that managed Medicaid pays us a base rate, which is below the cost of delivering care. So the federal government allows the states to tax hospitals, and they do in Oklahoma, and they use that tax to draw down additional federal funds. And it's these programs that we're at risk for losing. And it's these programs that would upend the work that each and every one of you are doing and your colleagues, whether it happens to be in the clinical side, the administrative side, or those that are providing very important support work to what you're doing. Nobody will be immune to these cuts. And so what you have in front of you is a slide that kind of shows you the impact of what this will look like. The first slide, the first column shows what Medicaid pays us before any of these supplemental payments, okay? Medicaid pays two hospitals $895 million to serve the Medicaid expansion population. That is below the cost of delivering care. So the federal government, as I said earlier, allows hospitals to be taxed and use that money to draw down additional federal funds. And for hospitals, it bumps that reimbursement for PPS hospitals. Those are our more community-based hospitals, an additional $900 million. Our critical access hospitals, our smallest hospitals, it bumps their reimbursement by $83 million. And from OU through the trauma program, which provides support for them, it bumps it an additional $352 million. You look at all of this here, it adds up to $2.2 billion. That $2.2 billion is what is at risk if we lost Medicaid expansion in our state. The last column shows you a particular Medicare reimbursement change, which is on the table as well, which would cost another $3.1 billion. That $3.1 billion is paid over 10 years, not in 1 year. So if you looked at the total of at risk for us is about $2.8 billion annually for the next 10 years. And that is what is scaring every hospital leader across the state because it will upend everything we do. Switch to the next slide. If you put this into perspective, what would these cuts mean to our state? The cuts to us would exceed those of closing down our military bases. Now, just a couple of weeks ago, we had members of Congress, we had other political leaders, all concerned about DOGE eliminating 400 to 500 jobs at Tinker Air Force Base. Flip to the next slide. This is the impact on us. I want you to just kind of put this into perspective. If you were a hospital leader and you had a reduction in your revenues and you had to then have a commensurate reduction in expenses to come out net zero, right? You would have to go to a couple places. You eliminate programs, right? Try and cut expenses any other way, but it ultimately comes down to our workforce. And the real concern for us is that there's no way to balance out these types of cuts without significant reductions in workforce. And so if you just do simple math of taking that base number and dividing it by the average compensation for hospital employees in our state, just do the math, divide 59,000 into 2.2 billion, it's 38,000 jobs. 38,000 jobs are potentially at risk for our state if Congress moved forward on this. The next slide. So that is our biggest concern, right? We lose Medicaid expansion, everything that goes with it. And yes, there are some little wrinkles in this because we do have Medicaid expansion in our Constitution. But if we lost the federal support for it, it would go away. If Congress decided not to eliminate that, but they wanted to tinker around the edges, it's still not a good tinkering. So if the government under a per capita cap said, we're going to cap your Medicaid program in Oklahoma, we're not going to add any more money, we're not going to contribute regardless of the cost of inflation, the annual loss to us would be $800 million. So that means our Medicaid program would have to be reduced by $800 million and everything that is associated with that. If the federal government said, we're going to change the way in which we pay for Medicaid expansion, our commitment as a federal government which currently pays 90% of the cost. In other words, they put in 90 cents and the state puts in 10 cents to pay for Medicaid expansion and the coverage for 300 million people, 300,000 people. It would still cost us $453 million. So the state will have to come up with that in order to be able to continue Medicaid expansion. If the federal government was to say, we're going to eliminate these special add-ons I showed you in the first slide, it would mean that we would lose approximately $600 million in federal funds to fund that enhanced payment for hospitals. And so there is no good answer to what we're doing other than for Congress to decline taking these types of cuts to providers. And so where are we? We have before Congress today, in the House of Representatives, in the Energy and Commerce Committee, they will have to decide on how to make $880 billion worth of cuts to our entitlement programs, to Medicare, Medicaid, Social Security, Kid Care, and a couple other health-related programs. Now, they can't get there if they don't cut Medicare and they don't cut Social Security. The only way they can get there is if they cut Medicaid. And that's what we're advocating in opposition to that. And so I want to put this all out there and just share this information with you, because what we're going to be doing is we're going to be asking hospital team members, we're going to be asking our partners that are focused on improving health and healthcare in our state. We're going to be talking and encouraging our clinical partners on this, as well as businesses who understand what the economic consequences would be if we had massive reductions in federal investment in our state, what that would mean. We're going to ask them to be part of our coalition to protect healthcare in Oklahoma. So you'll be hearing more about this. You'll hear more about it in the popular press. You'll hear it through OHA. You will hear about it perhaps in your professional associations. And we would encourage you to sign up, to receive the communications, to learn about what's going on. And if you want to become activated in terms of being able to share your concerns with members of Congress, you'll have that opportunity to do that through our coalition. If you're representing an organization that would like to be engaged in this and would like to be a full partner in our messaging to ensure that we represent all voices, all you have to do is email me, rich@OKOHA.com, or email Barbara, or email Emily, or any one of the OPQIC team members, and we'll get you plugged in. I cannot impress it upon you enough how scary this place or this position that we find ourselves in, those of us who are providing care to the Medicaid population. Now, I've been doing this now for over 35 years, and this is the scariest place that we've been in, where there is such genuine desire in Congress to essentially upend the programs that we have in place, not only in Oklahoma, but across the country. So I'll pause there. If folks have any questions about what this looks like, myself and Emily and a number of our hospital CEOs will be in DC in 2 weeks. We'll be meeting with our congressional delegation and our peers from across the country, all focused in on this as Congress takes up this issue. Now, the timing on this is that Congress will be back in 2 weeks. The Energy and Commerce Committee will start to have their hearings. You'll see a lot of this in the media. You'll hear from both sides of this. It'll be very emotional as this debate takes off. You will have the House essentially trying to push this through their caucus to get it on the floor of the House and pass it. It will not have a single Democratic vote. So it will be interesting to see which Republicans will peel off. There are a number of Republicans that come from expansion states that have genuine concern. You have deadlines that they have to meet. So this May and June are going to be jam-packed with all of this. And that's where we're going to need folks to help weigh in with their voices as we go forward with our congressional delegation. And let me just give you a couple numbers here, just to give you some perspective before I sign off here. If we broke up the state into congressional districts, let's just do that. In Congressional District 4, which is Congressman Cole's district, that district alone, which is Oklahoma City south to the Texas border, we're talking about the impact to that community of over $270 million in 1 year. If we looked at the Tulsa market alone, over $540 million reduction in that community as well. If we looked at the western side of the state, which is Congressman Lucas's district, over $225 million impact in that part of the state. If we moved to the, let's look at that, excuse me, District 2, my bad, that would be Congressman Burkeen on the eastern part of the state. That's approximately $225 million. On the western side of the state, which is Congressman Lucas's district, that would be $160 million of impact. And here in the Oklahoma City area, we'd be looking at an impact of over $520 million. Those are the cuts that the hospitals, and it's easy for us to pull the hospital numbers. We don't have the physician numbers in our hands, and we don't have everybody else that benefits from Medicaid expansion. But just on the hospitals alone, that is what we're at risk in terms of a reduction in revenues, which ultimately would correlate to a reduction in staffing and a reduction in the programs that we offer. At a time where we have such promise to add additional birthing hospitals, there is genuine interest in doing this. An effort like this would upend all of that. In all likelihood, it would result in perhaps more hospitals reconsidering providing obstetrical services, as well as other services that they provide to vulnerable populations. So I'm going to pause there. Barbara, if anyone has questions, feel free, to jump on and let us know. And we're happy to answer any questions that folks might have.
Thank you, Rich. I wanted you all to be aware of this risk because, Medicaid covers 52% of the births in Oklahoma. So over half, more than other states. And, this will affect all of us, all of you who work in hospitals and other partner organizations. Wanted to make sure you all are aware and you'll know what we're talking about when you receive future communications about this issue. So we hope that you all will become engaged in this because you are the voices that they need to hear. Our representation in Congress, our senators and congressmen need to hear from you all who are the ones who are actually there at the bedside caring for these people. So I just wanted to make sure you are aware of this issue and please spread the word so that we have more awareness throughout our state.
Yeah, just think about this for a moment. If a legislator is confronted with this question, do I fund grandbabies or do I fund grandparents? And that's what legislators will be left with, that responsibility. All the work that we did to move Medicaid to 210% of FPL to cover moms and babies, we will have great pressure to reduce that in order to be able to fund reductions elsewhere. So the gains that we have made as a field coming together is going to be at risk, notwithstanding the gains that we've made for providing coverage for working Oklahomans.
Any questions for Rich? Well, thank you so much, Rich, for sharing with us this evening. And Rich is available if any of you have questions, or your partners, your hospitals, your agencies, please don't hesitate to reach out.
Thank you.
Thank you so much. Scott is running a few minutes late. So Melissa, if you can move down to Lori, are you prepared, Lori, to provide your update? And then we'll go back up to Scott.
Sure, I can provide some quick updates. I'm Lori
Thank
Essery.
you.
Good evening, everyone. I'm the Director of Family Support and Prevention Service, and I think most everyone's aware that with Joyce's retirement, maternal and child health rolled into FSPS, and it is a subdivision of our service area. I just want to touch on, I'm just going to really touch on one bill right now. It's House Bill 2298, dealing with prescriptive authority for APRNs. That bill is still alive. It passed the House and moved to the Senate. It is currently in Health and Human Services, and it has until April 24th to make it out of committee. So we are to keep that bill alive. So we are watching that bill and sharing information with our legislative liaisons, and are very hopeful that we'll see that bill pass. And also, I just want to share, I know I've had some questions about what is going on with Preparing for a Lifetime, and we are on a pause right now. We are doing a refresh for Preparing for a Lifetime, a little revamp. We will be rolling that out in the next couple of months. I think you guys will be really excited about some of the changes and direction we're going. We will share that information with everyone, and we really want you to be a part of that. So just stay tuned, and we will get up and running, I promise, very soon. And I think probably the most interest is going to be in Title 10, which was awarded to OSDH again on April 1st. We had no advance warning, and we're told on that day. So Jill has been extremely busy working on the updated work plan and budget, and so I'm going to let her share all about Title 10. So I'm going to turn it over to you, Jill.
All right, thanks, Lori. If you don't know me, I'm Jill Nobles-Botkin. I'm the Administrative Program Manager for Perinatal and Reproductive Health, and I was the Title 10 Director until they took the funds away, and now I'm the Title 10 Director again. So we're excited to have the funds back in the state. We were not expecting them. This is the first time in history that many people know about anyway, that federal funds have been awarded for this program without competing for them. And so we were a little bit surprised, but they reinstated our previous grant with a partial award. And so we're not exactly sure what that means. So right now, we're trying to navigate through any changes that have been made in the Title 10 program, because as you know, there's been a lot of changes in federal grants. So we need to catch up, and we did have to submit a work plan, updated work plan, and a revised budget for the partial award that they gave to us today. And I can say that was successfully submitted. And so we look forward to working with a new project officer and seeing what we can do with those Title 10 funds in Oklahoma. Glad to have them back at the health department.
Yeah, it's very exciting. Thanks, Jill.
And I do give a lot of props to Jill. She has worked really hard getting everything together the last couple of weeks. So it was a very quick turnaround and a heavy lift, and she pulled it off and got it submitted. And I saw the notice that was submitted and accepted, and so very excited about that. So, but that's really all I have to share this evening. So, unless anyone has any questions.
Does anyone have questions for Lori or Jill?
Thanks for the clarification, Barbara, because I forget not everybody knows what Title 10
this group may not know what Title 10 is. So that's okay.
Yes. Yeah, I saw you put that in there. Thank you, Barbara. Yeah, sometimes we just think everyone knows our language and speak and grants. So appreciate that.
No worries. Thank you both. And Scott is here. So Melissa, if you can go back up to Scott's slides. And Scott, I'm going to turn it over to you. Scott Toline is the OHA Vice President of Advocacy. So thank you for being with us this evening, Scott.
Happy to do it. As you can tell, I haven't changed yet. But I'm happy to be here again. Appreciate all of you and your time. And I'm going to cover some things that I think will be of material to you, but they may not. So whatever feedback you may have for Barbara about what would be the most helpful type of legislation to otherwise cover for you all, please get that feedback to Barbara because I want this to be useful to you and not just, checking another box on your meetings. All right. So OHA has their own legislative agenda, and so there are a few bills on that are working their way through the process. So if you're unfamiliar with House Bill 2048, this has to do with the 340B drug pricing program. This is a bill that has a significant financial impact for our hospitals across the state, as well as our federally qualified health centers, as well as the health department and the Medicaid agency. Um, and I'm trying to think of who else. The Department of Corrections actually, I think, has a $6 million savings through the 340B program. So it is a vital program that helps us stretch our scarce resources within our facilities. It has been moving through the process relatively well, but there is a lot of opposition from the pharmaceutical side, pharmaceutical companies, and I expect it to grow more ugly as the session moves on. I'm not sure if anybody has questions about that. I'm happy to take them as we go or anything afterwards. House Bill 1810, this is really just taking the Sooner Select prior authorization timeline, so Medicaid managed care timelines and stretching them out from 24 to 72 hours. This was at the request of OHA and our member hospitals as they've received a lot of denials when it comes to Sooner Select because they can't meet that 24-hour time frame. That is something that we asked for with the initial legislation as it pertains to Sooner Select. Don't see any issues with this making it across the finish line and getting to the governor's desk. Something that might be of import to this group, House Bill 1686 as it relates to sepsis. This has been an ongoing conversation about the lack of reimbursement for the timely treatment of sepsis within our hospitals. We recently had a conversation with some of the health plans at OHA and virtually. The plans quite simply just don't like the bill. And I think they will certainly work against the bill as it moves forward. Emily was involved in that conversation with OHA. So I'm kind of curious how this bill ends up at the end of the day, knowing that the health plans will certainly push back against it. They seem to not believe this is an issue, although we have the data to support that it is an issue for our hospitals. Next slide. House Bill 2298. This is APRN prescriptive authority. This is now being authored by the Speaker of the House as well as Pro Tem Paxton. It passed off the House floor 55 to 38 when it went through there. It will be heard next Monday in Health and Human Services in the Senate. I do believe some change might be coming to the bill. Do not know what those are. But I have heard that they feel that it'll get across the finish line. Now, House Bill 2584 for physician assistant in independent practice, these bills have been tied together up at the Capitol. So if one goes, they both go. I don't know why there was such a difference in how those votes turned out when it came to the 67 versus 26, 55 versus 38 in passage. I think there was probably a little bit more political drama behind the scenes in relation to those votes, and not necessarily that it had to do specifically with APR and prescriptive authority. Um, but these are two bills that, as an association, we are neutral on. We have historically been neutral on. My conversations with lawmakers when it comes to either one of these bills is that whenever any of these parties get into disagreements at 23rd and Lincoln, it's the patients that are often forgot about. And so that hopefully, that the hospital association can be that Switzerland that is able to work with all parties and ensure that we have something that is truly taking care of patients at the end of the day. I'm going to move past House Bill 2295. I don't think anyone would potentially care about that. House Bill 1600, this is the Lori Brand Bill of Rights. You may have seen some media across the state as it relates to this bill. I think we all know that today, regardless of this bill, that you as a patient do have rights. Um, if you don't know that, I'm sorry. But this has been a bill that has been brought forth by Mr. Brand. He had a situation. Unfortunately, his wife passed away earlier on, very beginning of COVID. And he has been committed to doing something about it, making sure patients' rights, voices, etc., are heard. We have worked with both Representative Guys and Senator Hines as it relates to the language in here. They are aligned with CMS COPs, so it should not cause a issue for our hospitals and facilities. House Bill 1630. This is a hybrid medical facility licensure bill. You may or may not be aware, there's a group out there in Oklahoma that calls themselves the Patient Choice Coalition. And really what they are, if you have seen any sort of freestanding ER, they tend to be represented by these gentlemen at the Capitol. Um, they have always been looking for a way to create a hybrid licensure model scheme that exists out of reimbursement for CMS. So, if you can be reimbursed by CMS, if you're a hospital, if you're an ER, if you're an urgent care, but this type of hybrid model has never been recognized by CMS for reimbursement. OHA is generally always opposed to these, as typically if you go there, you could end up with an extensively high medical bill because they are not in network. And that is by choice. They choose not to be in network. They don't participate in Medicare. They don't participate in TRICARE. Senate Bill 740, this is a bill that had a lot of conversation as it moved its way through the Senate and into the House. This bill modified the definition of a person in need of treatment. And so those who are suffering from mental illness, etc., we were deeply concerned that the way they modified the definition, plus under current law, you have to meet criteria to otherwise be picked up and homeless and brought to a hospital. It removed that need to meet criteria. So just de facto, because you were homeless, you could otherwise be picked up and brought to a hospital or a community behavioral health center, etc., for treatment. Obviously, there's a lot of concerns around civil rights in that area, etc. We are very concerned that that would then put much undue pressure upon our hospitals and their ERs. But that bill, knock on wood, doesn't appear to be moving forward anymore this session, but I have one more week to see if that does come to fruition or not. But as of today, I don't see it moving forward. Senate Bill 875, this has to do also with Senior Select. There's a provision in the Medicaid managed care statutes that says the contracted entities, so the private managed care companies, the insurance companies, have to spend 11% on primary care. This bill would modify that and say that if you don't hit 11% during the next procurement cycle, so the next time that the healthcare authority would otherwise bid out for who's going to run the managed care program, that you would have a ding on your scoring. And then the second bill, or the second piece of that bill, would say if you don't hit 8% on primary care, then you would be completely ineligible to be awarded a contract for Senior Select moving forward. And then it provides for liquidated damages as well. The bills had title struck. I haven't heard any conversation about that necessarily being restored yet in the House. I know that there are certainly some plans that don't like it, but it's one of those things where it could continue to move forward. I was speaking with one of the lobbyists who represents the interest that's pushing this bill, and it seems as though any sort of conversation about this bill being attacked by the health plans, which would have the most to lose in this conversation, really, they are not putting up opposition, at least overtly at this point in time. And I believe that is all the bills I have. Is there anything that I didn't cover or anything that I talked about that you would like to talk about? I'm happy to do that.
Scott, I have a question
Yeah.
related to House Bill 2298. Where, as the State Health Department, we are following that bill, and I understand you're neutral on it. Obviously, it would be beneficial to us in recruiting and hiring APRNs and allowing us to better serve our folks in rural county areas. But I'm just curious. I know that it is in committee and you're expected to be heard on the floor. We're watching it closely too, but it was vetoed last year. So I was just wondering if you had any buzz on that again.
Yeah, I mean, I think that's the million-dollar question is, does the governor's position change? I've heard there have been some conversation with him beforehand. I mean, and this is me being a truly neutral party, that bill, the way it was drafted and ended up on the governor's desk, I am shocked that no one caught a big deficiency on that bill and where it was drafted and how liability would end up falling, because it grabbed in like veterinarians, etc. So it did have a structurally deficient piece. But to your point, the governor's veto message was very specific about APRNs not needing this authority. Um, I think that's interesting, in light of this bill moving forward, and if it gets there, does he have that same tact? I know that many parties have met with him in the interim to see if he would otherwise change his mind. At the same time, there are a number of physician groups that are supposedly okay. I say supposedly. I say that very strongly because they had a list of items that they wanted to discuss with leadership in both the House and the Senate. And that was in exchange for these bills moving forward because they don't want the fight to continue either. Nothing's ever, we say at the Capitol dead, right? And so I I imagine that if both the speaker and the pro tem are willing to put their name on it, they will probably also be willing to bring it back and do a veto override if it happened to get vetoed. Um, but there's a lot of stuff going on right now with the governor and the speaker of the House due to forestry and other matters, and all those little elements complicate anything moving forward. And that could happen to our legislation, right, as well. So if I'm reading the tea leaves today, if those conversations have happened, then I think, yes, it probably does get signed. But if those conversations have not happened, then it probably won't get signed. But, then it comes to who wants to put it back up for a vote and override the veto. I don't know. I don't see the issue going away. I mean, this has been worked on
We
for,
need it.
I
Yeah.
mean, yeah, 4 or 5 years heavily at the Capitol. I mean, there's
Mhm.
been numerous election cycles where, Senator Stanley was the one who was running this bill previously. That as one of the things that the physicians wanted was her name off the bill. They spent $90,000 against her in her last election cycle because of her continued support and running of this bill. So they're certainly willing to spend money on it, but it's how much money and for how much longer are they willing to spend money on it? Um, yeah,
Yes. Well, thank you. I mean, you gave me a lot to
yeah,
consider, and it was good information though. So,
Mhm.
I mean, I'm hoping some conversations have happened. So, I'm gonna think positively and just believe maybe that has happened, and we'll see this come to fruition. Thank you.
yeah. You're welcome.
Thank you. Are there any other questions for Scott while he is with us? Well, again, just want to make sure you all are aware of what's happening at the Capitol. Um, it's a good thing to stay engaged and feel free to reach out to Scott or reach out to me and I can connect you if you have any questions, and just want to make sure that you have an understanding of things that are going on. And if we ask for, that we may ask for some support for things moving forward. So we appreciate your being with us this evening, Scott.
Yeah, happy to do it. Appreciate it.
Thank you.
Bye.
Okay, it looks like we are next with OPQIC. Um, we are getting updates from the Oklahoma Healthcare Authority, but their person providing updates has some conflicts and cannot be here till 6 o'clock. So she's going to go after me. So I wanted to provide you all with some updates from OPQIC for the evening. First, we wanted to share that we shared two posters at the Alliance for Innovation on Maternal Health meeting in February in Washington. As you can see in the picture, I had already changed for travel for the day. So we had a great time at this meeting, and we shared a poster on teen birth and a poster on low-dose aspirin and pregnancy. So we are excited that we are able to attend the Alliance for Innovation in Maternal Health annual meeting. We also wanted to announce we have two more teen birth hospitals that launched in Oklahoma. Integris Lakeside and Woodward launched. Their pictures are here. Great fun doing the Lakeside and Woodward launches in the previous months. So we only have a couple more hospitals that have not launched on teen birth, and we're still working on those. We also want to share we are the state. I just checked. Massachusetts also, if their information is correct, also has 5 hospitals, but we have 5 teen birth recognized hospitals. OSU Medical Center, Integris Health Edmond, Hillcrest Medical Center, Northeastern Health System, Chickasaw Nation Medical Center are all officially recognized. And what this means is they have structures in place and processes that ensure that they will be sustaining the practices associated with teen birth. So it's hard work, but we want to have all of our hospitals in Oklahoma be officially recognized as a teen birth hospital. So congratulations to these 5 hospitals in Oklahoma. I'm going to turn it over to Melissa real quick to talk. I know we've done some provided information about low-dose aspirin. Just wanted to share a couple of brief points about low-dose aspirin.
Hi, everybody. My name is Melissa Ward, and yeah, I just wanted to give you a quick update on where we're at with this effort to reduce rates of preeclampsia and preterm birth in Oklahoma. So just as an update, there were some changes to how you diagnose preeclampsia a few years ago. So it used to be that you had a high blood pressure reading of 160 over 110 in the presence of proteinuria. That diagnostic criteria has since been changed to where it's now a high blood pressure reading of 140 over 90 and the presence of proteinuria or physical manifestations such as a severe headache or upper right quadrant pain. So we have noticed that there have been significant increases in rates of diagnosis. There was a paper that came out last year that found from 2010 to 2021, the rates of preeclampsia essentially doubled nationwide. So it has become a big focus of a lot of different groups, including the American Heart Association, to combat this epidemic that we're experiencing. And also in light of it being Black Maternal Health Week, I think it's also important to note that Black women experience preeclampsia at 3 to 4 times the rate of their white counterparts. And we can see this in the data in Oklahoma as well. And in correlation with that, we also do see increased rates of preterm birth in our Black population in Oklahoma. So we need to discuss increasing the recommendations to women who could be at risk for getting preeclampsia. So in Oklahoma, not only Black race, but we have had some providers recognize that our American Indian Alaska Native population is also at an increased risk for preeclampsia as well. So just bringing awareness and attention to that. And so our recommendation is really just to ensure that all pregnant women are screened for low-dose aspirin eligibility. So if they have any of those high-risk factors, one high-risk factor, or a combination of any 2 moderate risk factors. Back in February, I served as a reviewer on the change package for low-dose aspirin that was created by the California Maternal Quality Collaborative. They worked extensively with 5 different groups at major health systems with high-risk populations across the state of California to develop screening methods and education for those health systems that serve those high-risk populations. They put together a toolkit. I collaborated on that, and then also they will be implementing some of the things that we have created within our own toolkit. So that's an exciting development that we hope to see the outcome of soon. We are still able to provide brochures to any health systems that would like it, and those are of no charge. You can just email me here, or you can also access our toolkit online. So if you are looking for some of those screening forms, those will be available on our website as well. We also did run a successful social media campaign, and that will be resuming next month for Preeclampsia Awareness Month. With our previous campaign, we had received over 3 million impressions of our posts on social media. So that was really exciting to see. And I love hearing from people that say, yeah, I think I saw something about that on Facebook or Instagram. So just be aware, you may see some soon next month. And we're possibly going to do another media outreach to see if we can get one of our providers in the state to speak on this on camera. So that is all the updates that I have on low-dose aspirin, and I am going to turn it over to my colleague Evelyn so she can discuss Maternal Mental Health Month.
Evelyn, before you start, I just wanted to share. Yeah, there's been some talk out there that we're promoting that everyone get aspirin. We are promoting that everyone is screened for aspirin therapy. Some providers do choose to do universal aspirin for pregnant people, and that's fine. That's their medical decision. But we do have the tools that are there for you to be able to use to screen whether your patients are eligible for low-dose aspirin therapy. So please utilize them. We estimate that over 70% of our population in Oklahoma would be eligible for low-dose to receive the therapy, and that begins ideally between 12 and 16 weeks of pregnancy. And Melissa's really done a great job with this. Usually California is leading the way of all collaboratives, and they actually reached out to us for some of our things. So we were pretty excited about that. So just wanted to shout out to Melissa for that.
Thank you.
So, okay, Evelyn.
Thank you, Barbara. Good evening. So as we are heading into May, we have perinatal maternal mental health day and mental health month that we'll be focusing on. Melissa will be helping with a social media campaign for this, and this will also be in conjunction with our work group area of focus that we're going to talk about here in just a minute. Go ahead and go to the next slide, Melissa. And then here are some other campaigns that'll be happening through Postpartum Support International and the Perinatal Mental Health Partnership. So just wanted to share those. You'll be seeing some of these on social media as well. You go ahead. So I wanted to talk about our maternal mood disorders work group that's been existing for quite some time now through the Preparing for a Lifetime initiative. And as that's on pause, we will continue to support that through OPQIC as part of our AIM patient safety bundles for maternal mental health and substance use. So currently, Dr. Alicia Lilly and I co-lead that work group, and our work group consists of many partners from across the state, community agencies, providers, and nonprofit organizations. We meet on a bi-monthly basis, and we've put together a work plan last September to focus for 2025 on 3 areas, and those areas being awareness, screening, and referral resources. And so within our work group, we have divided our team up into smaller committees focusing on these areas. The awareness group focused really on social media campaigns and just bringing to the attention all of the different resources that are available as we have like Maternal Mental Health Month and Week and things like that. And on the screening side of things, our committee is working on a survey that will be distributed to providers across the state to gather some data on whether or not they're doing screening in their clinics. We also provide a survey to our hospitals that we ask these questions to. What type of screening are they doing? Are they using a validated screening tool? And if they need more information. And so that's the area for, that's what that committee is working on. And then our referral resource committee is working on updating referrals across the state. And on our OPQIC website, we do have a referral area that people can search for assistance throughout the state of Postpartum Support International certified mental health workers and other workers across the state. Next slide, please. Recently, we went through and updated our website and changed the name from OMNO for this section to Perinatal Substance Use and Mental Health, and also kind of renaming the link to OK Mama, which stands for Oklahoma Maternal Addiction and Mental Health Assistance. And just trying to bring the two together as they're very closely related. We have gone through and updated our links within the site, as you can see, located in the green box down there, broken down into toolkits and screening tools available, as well as other supplemental resources and training. So if you have any information that you'd like for us to add to this area, please reach out to me and I'll be happy to look through it. And we're adding and updating things all the time as new information is coming out. And as I mentioned, we do a quarterly survey for our hospitals. And so for those of you who are on, we just submitted or sent out the latest survey on Monday, and it has been renamed to OK Mama. So I just wanted to let everyone know that it's very similar to the previous OMNO survey, but the maternal mental health questions have been added to this survey. So please get that completed and sent back to us if you have received one in your email box. And just some reminders of the available hotlines. Please use these in your clinics, your hospitals to recommend to your patients so that they know how to seek help. There's also a perinatal mental health toolkit through ACOG that is available for providers as well. And we have an upcoming perinatal substance use echo that is available. Just scan the QR code, and this is actually not sponsored by OPQIC, but the ECHO program. This one happens to be through Minnesota, but anyone is allowed to register and listen in on these ECHO programs. And Earlier today, a new report came out from the Center for Healthcare Strategies addressing maternal mental health and substance use disorders. Behavioral health conditions, including mental health and substance use disorders, contribute to more than 20% of pregnancy-related deaths in the United States, worsening the maternal morbidity crisis. And so these infographics here highlight some of the outcomes of the report, but you can go to the full report using the link at the bottom of the page once these slides are sent out. We will also be sharing these on our What's the Latest newsletter and adding these also to our website. In addition, when you go to this link, there is also a webinar that was from last October, called Improving Health Outcomes for Pregnant and Postpartum Individuals with Mental Health and Substance Use Disorders. And again, that webinar is open and available and free right now. And I believe that's all I have for now. And feel free to reach out if you have any questions or you're interested in participating in our work group. Thank you.
Before we move on, Evelyn, there's a question from Alexis Hamilton asking, is there a campaign toolkit for the Maternal Mental Health Awareness Days? Do you know if any of those groups that you shared have any toolkits for, are you talking about a social media toolkit, I'm assuming, when you say campaign toolkit, Alexis? Are you aware, Evelyn, if there's...
Yeah, so I just saw today that the Blue Dot, I think it's called bluedot.com or .org, is releasing through the Postpartum Support International. They usually release a social media campaign, and so we will have links to those on our website in our mental health area of the website as soon as we get those uploaded. So I just literally saw those come out today as I was looking for some of these because I knew they would be happening pretty soon. And then it's the one, if you go back to the slide with the purple lady in it, it's the one that on the right, the Maternal Mental Health Awareness Week, that save the date with the blue dot. That's the one that's going to be, they'll have a toolkit for campaign. So we'll be sharing that as well. Hope that's answers your question.
Thanks. And you can go to our website, go back when, Melissa, I want you to stop real quick on the Maternal Mental Health Hotline. Alexis, on our website, there's a way you can subscribe for updates. If you haven't already, someone can put the link in the chat to subscribe for our What's the Latest monthly updates, and we'll put that in there. I want to make sure that we highlight this maternal mental health hotline. We've done it before, but mental health and substance use disorder are the leading contributing factor to death in the United States during pregnancy and postpartum. That is going out for 1 year after giving birth, and want to make sure that everyone who gives birth or is pregnant has this number available. That this is minimally what we can do to provide our patients with support. I know that some of our providers have been limited recently, and we may not have easy access to providers, but we do have 24/7 access to this maternal mental health hotline. So there are some brochures, there's PDFs on our website that you can print off, and just want to make sure that everyone is aware of this. Okay. Now, if you can go to Katie's slides on OB readiness in the emergency department.
Thank you, Barbara. Good evening, everybody. Coming to you with some new information on the OB readiness in the emergency department. We are holding 2 more workshops for the A1 OPS course. Those will both be in May. May 2nd will be at Stillwater Medical. May 22nd will be at the Canebrake Resort. It's being hosted by Wagner Hospital. So these will both hold 32 spots. We're really hoping to have some of our ED staff, providers, nurses, EMTs, and then also our labor staff that works with our EDs. It's great to have them both in the room together to have these conversations. So if you are interested in either of these, the registration link is on our website. It will be on the email that goes out to you guys. It's a wonderful full day class. If you had previously registered for this back in June and were unable to attend, please reach out to me and let me know. We can probably get you into one of these dates, and so you're able to use that certificate from A1. We'd really like for you to come. And then the next page actually just came out today. We've had a lot of really good information released today. So AIM is hosting a learning sprint. This is all we know so far, that it will be the obstetric readiness learning sprint. So this is geared towards our EDs and EMTs, an absolutely wonderful resource. So it talks about the following sessions that they'll be holding. Obstetric care in the rural environments, which we know is quite an issue here in Oklahoma with our maternity deserts. Pre-hospital emergency care, this will be geared towards our EMTs and EMS systems. OB simulations in the ED, planning and assessment of OB emergency readiness, and obstetric care assessments for resource limited environments. So we will make sure that we get this out to everybody whenever we get the information when they'll be holding these and on the dates. And I'm passing it on to Denise.
Before we go to Denise, sorry, I just want to emphasize that CMS is requiring hospitals, all hospitals, to and those that do not deliver babies as well, as a condition of participation. Am I saying that correctly? Emily, you can, and Katie, y'all
Yep,
can
you
make
got it.
sure. Okay, that you have a plan for OB in your emergency department, and this takes effect on July 1st. So all of you of this year, so your hospitals should all be working on this. There is information we can connect you to find out more here, and it's on our website and at What's the Latest, but reach out with an email if you have questions. And this is a way that can really help you to work towards ensuring that you have people that have been trained and gone through simulation and things like that of obstetric conditions who work in the emergency department. So just wanted to emphasize that and make sure everyone's aware, and hopefully we'll see a lot of you at these classes coming up soon. Okay, sorry about that. Go ahead, Denise.
Barbara, no worries. Good evening, everyone. I'm Denise Cole. I'm part of the OPQIC team, and I wanted to share with you some of the award criteria that we have recently decided we'll be utilizing to determine our Spotlight Hospital Awards this year for 2025. For those of you who are unfamiliar with the award, this is something that we've been giving out now for several years, trying to reward hospitals who are participating in the many initiatives, like many of the ones that we've been discussing this evening. We know that there are certain practices that have been shown to help reduce maternal and infant morbidity and mortality. And there's a lot of hard work that our hospital partners are putting in to try to address those issues and to try to give the best care for Oklahoma's moms and babies. And so these criteria are meant to reward those. We are going to assess the award criteria on September 30th of this year, and then recognize hospitals at our annual summit in November. So next slide. The first area that we're going to be recognizing are our perinatal care measures that are available. We know that PCO2 and PCO7 were required to be reported to CMS by hospitals who were receiving CMS funding beginning in 2024. And so those are usually a year out to release the rates. So we should be seeing those 2024 rates being reported any day now. And the two measures, PCO2 is the cesarean birth measure, and this is also for first-time pregnancies with a single-term infant with the head down. It's also referred to as NTSV for nulliparous singleton-term vertex. And really what we're looking at for our point assignment is looking at the Healthy People 2030 goal for that measure, which is around 23.6%. So any hospitals that are at or exceed lower than that 23.6% rate will receive 3 points. And then hospitals that are between 23.6 and 26.8% would receive 2 points. Between 26.8 and 30%, 1 point. And then the cutoff measure or the benchmark that CMS and the Joint Commission are using is a rate greater than or equal to 30%. The other measure is PCO7, which is severe obstetric complications. And this is trying to measure hospital performance in attributing to severe maternal morbidity and also including maternal death at the facility. So those rates, we have not really seen any data yet to know what the national average might be according to when CMS releases those rates, but we are using the national average as our benchmark. And so hospitals who have a SOC rate below the national average will be receiving 2 points. Next slide. Also from CMS, we can acquire whether or not a hospital is designated as birthing friendly. This is not to be confused with baby friendly, which is the breastfeeding designation, but birthing friendly is a designation that CMS is granting to hospitals who participate in a statewide or national perinatal quality improvement collaborative program, such as OPQIC, and implements evidence-based care practices to enhance maternal health outcomes. So really, this is a structure measure that is self-reported, and hospitals say that either yes, they do, or no, they do not meet those criteria. And so hospitals that are designated as birthing friendly will receive 2 points. Currently, we have almost all of our hospitals who are designated as birthing friendly. And then with breastfeeding, for those hospitals that are baby-friendly designated, we're going to give 3 points. For hospitals that are on the baby-friendly pathway or part of OBRC's AIM High program, trying to help hospitals to become baby-friendly, can receive 2 points. And then we know that not all hospitals are on the pathway or designated as baby-friendly, but there is another measurement of breastfeeding practices, and that's the MPINC score, and it stands for the Maternal Practices in Infant Nutrition and Care. And that's a self-assessment that is hospitals can submit to try to assess their own or rate their own breastfeeding practices. So an MPINC score of greater than 90 will also be awarded with 2 points. And then a current MPINC score that's above the Oklahoma national average but less than 90 will receive 1 point. For hospitals that are trying to encourage families to practice infant safe sleep habits, so trying to reduce those risk factors that we know that are possible leading to sleep-related deaths, there is a Cribs for Kids safe sleep certification that is possible. And really that certification just hospitals are eligible to apply for that if they have hospital policies that they are ensuring that families are educated and that the safe sleep practices are modeled by the nursing staff and other staff within their hospital. And they have 3 different levels of certification. And so we're awarding points accordingly to hospitals who are certified. With OK Mama, I know Evelyn introduced our new OK Mama name earlier in our meeting, but that is our Oklahoma Maternal Addiction and Mental Health Assistance Initiative. We are kind of expanding it beyond what we've done in the past with OMNO. And she mentioned that survey. So hospitals that do complete that survey will receive points towards Spotlight Award. And then hospitals that participate in some upcoming activities that we have related to OK Mama will also receive points. So we anticipate to roll this out in sprints. If our sprint is in full swing, as we assess these criteria later in September, then we will give 2 points for hospitals that are participating. If we're in a commitment phase, we'll give you 1 point for committing to participate. So more to come on OK Mama. We also want to recognize hospitals that are participating in Team Birth. Those hospitals that have achieved national Team Birth recognition are going to receive 3 points. Hospitals who have applied for recognition designation are going to be given 2 points. And we have some hospitals that are fully implemented with Team Birth, but you have to have launched or been implementing Team Birth for at least 1 year to be eligible to apply for recognition. So hospitals that are in that midpoint where they're not quite eligible to apply, but they are fully implemented, we are granting 2 points. And then hospitals who are eligible to apply but have not applied for recognition, but are implementing Team Birth will be given 1 point. The Joint Commission has a perinatal care certification, and for those hospitals that achieve this certification, we are awarding 3 points. This certification is offered by the Joint Commission, but hospitals do not have to be accredited by the Joint Commission to apply. So this certification is actually open to any birthing hospital. And as a way to encourage hospitals to start utilizing our Empowering Pregnant and Postpartum Patients Toolkit, we do have a way we're going to be asking for you to report what percentage of patients you are distributing some of those materials to, specifically focusing on the post-birth warning signs handout and the helpful information and resources handouts. So you'll be given points for distributing those to your patients. And speaking of this toolkit, later this month on April 30th, we're going to be having a webinar where we describe the toolkit and the resources that may be available. So this is a webinar, we're doing it as a lunch and learn, so it's at noon. You see there is our registration code. We'll also send this link out in the slides after the meeting. But really what we're going to be discussing on this webinar is what resources are available and how you can utilize these toolkits. So this webinar isn't necessarily patient-facing, but it's more for providers, clinics, and hospitals as we encourage you all to utilize these resources to be given to patients. We know that some of these could save a life. And then last but not least, we are offering points for hospitals who are high performing with newborn screening. So there's 2 different things that the newborn screening program measures, and that is the transit time. So how long does it take for the specimen to arrive from time of collection until time of arrival at the lab to be analyzed. So we're giving awards 3 points to hospitals who have greater than 95% of their specimens that arrive within the 48 hours, which is their recommendation, and then 2 points to those who have between 90 and 95 arriving in time. We know that newborn screening is a very timely situation for those infants who do end up having a potentially lethal metabolic disorder, then those hours matter for them. So we're really focusing on transit times as well as the specimen being satisfactory for analysis. And so we call those our unsat rates. We're looking at hopefully less than 2% of the specimens that are sent to the lab are unsatisfactory, meaning that 98% or more are satisfactory for analysis. And so we have a point tier system there. We will be sending out these criteria in a document and then providing resources for each of the areas of recognition so that hospitals who are wanting to know how they can meet those criteria, we are very willing to coach and support you along the way, and just let us know if you have any questions.
Thanks so much, Denise. Are there any questions now on the meeting? During the meeting? Thank you. Well, reach out if you have any questions for us, and we will be releasing those soon. We believe that CMS is going to have the first public reporting of the PCO2 and PCO7 numbers sometime this month. So we will share that information when it comes out. And we are also pleased to have Falake Adedeji as the Chief Quality Officer at the Oklahoma Healthcare Authority. And Falake, are you able to join and share your updates with us now?
Yes, ma'am. I'm so sorry.
Thank you for being here.
I had a conflict. I wasn't looking at my calendar.
No worries.
So thank you for being flexible. So hi everyone. I mean, I'm usually on this meeting, so I think I know everyone, and I should be a common face now because I'm sure I work with a lot of you in different spaces. So I'm gonna just talk through some of the things that are going on at the Healthcare Authority. Next slide, please. And just as my notes, like, okay. So I don't know if all of you remember, but April 1st was when we implemented Sooner Select. That's our managed care program last year. And so we're kind of celebrating the 1-year anniversary of going to the MCOs. It was a year for the medical plans. The dental plans was in February, but for the medical plans and the children's specialty plans that focuses on foster kids and youth, we implemented April 1st of last year. So we've actually made it through a whole year of managed care. And so I think there's a celebration sometime this week just to mark the 1 year. Also, in addition to that, we have open enrollment starting May 1st. So when we went to managed care, we have 3 healthcare plans that we partner with that a lot of you probably work with. So we have Aetna Better Health of Oklahoma, we have Humana Healthy Horizons, and then Oklahoma Complete Health, which is a subsidiary of Centene Corporation. When we implemented last year, we took all of the population that we used to manage and we divvied them up between those 3. And then for the CSP, which is also a plan that the Oklahoma Complete Health offers, we moved the foster kids and some other youth in there. When we move them around, we give them the opportunity to either move around, choose, and then after a while we close that. But every year we go through an open enrollment period that allows them to move either the plan or provider. And so that's going to be starting May 1st, and it'll run for 6 weeks, and members will be able to change their plans, their providers, and then after that we close it, and then they stay where they need to, where they've chosen or where they need to stay. So I'm just putting that out there that's going to be happening. The other thing that's been really big for us, which I mean kind of lives in my area but kind of cuts across finance and the plans, is when we put out the RFP, we asked that the managed care entities who would be applying would be ready to increase primary care spend in the state of Oklahoma to 11%. And so in the last couple of months, we've been working through what that would look like. So we have two groups or 2 buckets. So there's the claims spending, which is anything that comes across to us on claims. And then there's the non-claims spending bucket, which is a lot of things that's been defined that would impact primary care. And examples of those are delegated care management. So for example, if one of the plans decides to contract with OU HONS, for example, or OSU HONS, we will count that as non-claims spend. Or if they give a grant to a foundation that's working to improve access to primary care, we would count that as part of the 11%. So a lot of work has been kind of going on to try to define what primary care spend is, how we're defining primary care spend, what specialties, well, not specialties, but what constitutes primary care spend on the claim side. So OBGYNs, family medicine doctors, and some other provider types fall into that bucket. And then for the non-claims one, we've looked at things like the value added benefits that the plans offer. We've looked at some of the incentive payments or the bonus payments or the quality performance pay for performance programs that the plans have that's directed towards primary care. So we're going to count all of that with the hope that they will hit 11% by their 4th year. So right now, as the healthcare authority, we don't do any non-claims. Everything we do is claims, and we're at about 5.5%. So we kind of have that going on. And I don't know if you know, but there is a Senate bill that, and I think it's Senate Bill 875, don't quote me. If you look for Senate Bill 875 and it's not it, I can find you the right one. But there is a bill out there that holds the plans to this 11%, and it has language around if they don't hit between 8 and 11% in year 4, they may be penalized, and they may not be they may be penalized. But if they don't even come near, no, if they hit between 8 and 11%, they may have to pay some damages, or there's some kind of stipulation that they have to fulfill. But if they don't come near the 8%, they may not be able to rebid as a vendor or as a managed care entity in the states of Oklahoma. So the plans are really working, hard to try to figure out how to hit that 11%. And then the team of work just continues to go on in its planning phases, in its planning phase. We do have a 3-year runway before its implementation. We're working with CMS, we're working with contractors. We've turned in a bunch of scope of work to CMS, and we're waiting on approval so that our contractors can actually start the work that we've said that they will be doing with us. Does anyone have any questions? And if I'm not able to answer, I can take it back and provide an answer later.
Thank you, Falake. We did talk about that in Scott Tolene, our Vice President for Advocacy, talked about that bill as well.
The 11%.
Yeah.
Yeah, we're really excited because it really is geared towards building the primary care infrastructure across the state. And it's really directing the plans to put more of their spending into primary care. So we're working through it with them and internally as well. But I mean, I'll be happy to, if you think of something, usually I can drop my email in the chat, or if there's anything you want updates on, just shoot me an email. If I don't know the answer, I'll find it for you.
Falake,
Yes. Thank you,
is
Falake. Falake is very responsive. So she'll put her email in the chat. And if you have any questions, feel free to reach out to her or reach out to us, and we can
Barbara.
give an answer.
Barbara, this is Jill.
Uh-huh.
Falake, I want
Yes, ma'am.
see if you could give us an update on where the progress we're making for reimbursing doulas and non-nurse midwives, because that's a part of this grant that I'm working on. So I know you're working on it. If you could share.
We already reimbursed doulas. So that's done. Right. We did that like a year ago, or it might be almost 2 years now. So the one that we're working on is the Senate Bill 1739 from last year about the birth centers, like nationally accredited birth centers, the midwives, and then the certified midwives, and then the certified professional midwives. We're currently in the process of promulgating the rules that should guide. They've been put in place, but there's a little bit of a hang up between some language in the rules. And so we're working through that with physicians and midwives and birth center owners to make sure that everyone is in agreement with the rules before we put the rules out before the board. So it's advanced way past started from a couple of months ago. But I think there's some language challenges that the midwives want it in a particular way and the physicians want it in a particular way. So we're trying to find a happy middle for everyone. So it's in the works for sure. As soon as we pass the rules, I'll be here to update everyone on the rules being passed.
I knew it was, yeah, they were open for comment. So
they got a lot of comments. They're working through the comments as well.
Thank you.
You're welcome.
Thank you so much, Falaki. And before we adjourn, I had a hospital reach out to me recently that talked about some of the rural hospitals that are close to them or not so close to them, but near in their area, that if they have had pregnant women present to their emergency department complaining of ruptured membranes, these hospital emergency departments have done a nitrazine test, which tested positive. That was the only test, and then transported the patient to the birthing hospital via an ambulance. They did more of a comprehensive exam, and often these patients have not had ruptured membranes, and then they don't have transportation back to their community. So I wanted to ask other hospitals what you all do for your testing. We know, I think the gold standard is to do the Fern test and, with a sterile speculum exam, and that Amnisure can be used as a secondary test. Wanted to ask you all that are here if you have any insight that you can provide for how you handle the situation. Or if you know what other hospitals in your area that don't provide obstetric services, how they are evaluating for ruptured membranes.
Barbara, I think if their physicians are uncomfortable looking for ferning or don't feel trained to look for ferning, their only other option would be Amnisure, and their hospital would have to invest in the testing swabs for it in the lab.
Yeah, I think too, some could send to the lab to evaluate. Jennifer Smith said that she thinks they need to be seen by an OB. So that could be maybe doing a consultation, Dr. Smith, with the nearest OB hospital as to how they should be transported. Do you want to come off mute, Dr. Smith,
Sure.
to provide any input?
Can you hear me?
Yes.
Okay. Yeah, so I think that there's a lot of nuance for people who present with possible ruptured membranes that really needs to be evaluated by an obstetrician, depending on gestational age.
Right.
Amnisure shouldn't be used at all. Ferning, you may not always see real early in pregnancy, even though they are ruptured. So I think that to make sure the patient is managed appropriately, that they really need to see somebody who has a good clinical understanding of the tests and the physical exam and ultrasound and all the things that we use to assess these patients.
And Barbara, I think a phone consult won't be helpful either, because any OB is going to tell you they're not going to be able to know unless they lay eyes and hands on the patient. And then figuring out how they get there is difficult as well, because, we get calls from ERs all the time that say they're completely dilated and they're 1 centimeter and they just couldn't feel the cervix, or the opposite, they call them 2 centimeters and they get here and they're complete. So it's really hard to say how would you let them go by private car, or would you send them by ambulance? It's hard to say because it's hard to know their comfort level with evaluating where they're at in that process.
Yeah, that's good input.
Well, it's just, to add on to what Dr. Jennifer Smith said, it's, nitrazine in and of itself is very non-specific.
Right.
And the skill set it requires to do the more specific testing is probably not matched at a lot of these facilities that don't have obstetrical services. So it's a bit of a difficult situation how to navigate. I mean, I would say you want to err on the side of sending the patient to be certain rather than potentially have a patient be discharged or misdiagnosed with an actual condition.
Yeah, good input from you all. So I will share this input. She just asked what other hospitals were doing, and I said, well, I'll find out. So anyone, April, looks like you said you would find out. I appreciate that. Anyone else want to join in? Well, thank you all. That was good feedback. I knew that I could get some quick answers for her from the experts out there. So we appreciate your input. Any other questions or other business that anyone may have? Hearing none, I wanted to make sure you all are aware that our next meeting will be July 15th, and you can sign up to receive an invitation for all of our quarterly meetings or just one quarterly meeting through our website. So please access that and to get the invitation. We will be sending you all the slides in a PDF and any other information along with in an email following this meeting. The Zoom link is always the same for this meeting. So thanks, Katie, for sharing that information. So we hope to see you all in July, where it will be, I'm sure, a little bit warmer than it is now. Next slide, our upcoming events. Hope to see all of the nurses at the A1 Oklahoma Conference coming up here the 24th and 25th of April. So next week, we're excited to see you all there. April 30th is the Lunch and Learn, where we will talk about our Empowering Pregnant and Postpartum Patients Toolkit. May 12th, an A1 Education webinar, Empowering Nurses, Enhancing Care. May 16th to 18th is the ACOG annual clinical meeting in Minneapolis, and June 21st through 25th, the A1 National Convention in Orlando. So if you're interested in any of those events, we will have registration on our calendar on our website. Here's a QR code if you want to register now for the Oklahoma A1 conference coming up next week. And we also have the QR code to attend the Oklahoma A1 section, the Empowering Nurses Enhancing Care, on May 12th. These will all be linked on our website as well. And thank you all so much for joining us. I hope everyone has a great evening, and we hope to see you coming up at our events. Be on the lookout for our What's the Latest emails. Please email us if you have any questions, concerns, and we hope to see you at our next quarterly meeting on July 15th.